Standardizing psychiatric care, a model for diagnosis and treatment of major psychiatric disorders, video 3 of 4, psychiatric evaluation, pharmacological treatments and follow-up care. Video 3, psychiatric evaluation, pharmacological treatments and follow-up care. Psychiatric evaluation is the most important component in standardization of psychiatric care. In acute care setting, patient is evaluated by admitting staff, nurses, social workers and others before seeing the attending psychiatrist. In outpatient office setting, psychiatrist has limited information. Further, he or she has only 45 minutes to complete the evaluation and determine diagnosis and formulate a treatment plan. Since starting my private practice in 1991, I have performed psychiatric evaluations and treatment plans for over 7,000 patients. In this video, my model for psychiatric evaluation is presented. Further, my rationale for choices of medications, the order of their titration and combination with others are discussed in video 4 so as to achieve the lowest, most effective dose with minimum side effects and optimal functioning. If this model is followed by practitioners all over the United States and other countries, I have no doubt that medical expenses and disability in mental health will be reduced. Psychiatric evaluation, namely, first of all, identification data, name, sex, date of birth, age, marital status, sexual identification, referred by primary care physicians, therapists or others are noted. Further, I want to know what are the current list of medications, psychiatric, medical and also any kind of supplementary medication they are taking from over the counter. Further, the history of present illness, I need to know whether they have been hospitalized or have gone to the emergency room or intensive outpatient and also alcohol and substance abuse history, as well as attending any AA or NA meetings and any medical disability, treatment by primary care physicians, psychiatrists or counselors, and also what are the current symptoms. This is very important that you record especially current symptoms quite accurately because that is your only baseline data that you have. Further, I do want to know what is the past psychiatric history, namely have they been hospitalized in the past and how many times and when were those hospitalizations, and the emergency room visits, intensive outpatient, alcohol and substance abuse programs, and whether they have been to AA or NA meetings, have they ever had any counseling, and again what age and when they started and what was the reason for it. Further, have they been treated by primary care physicians or psychiatrists, and I also want to know what are the list of the medication they have taken and how long, whether they were useful to them or their side effects that they experienced. It is very important to get the history of suicide attempts, suicide thoughts, and whether they are having any current suicidal thoughts, intent, and any possession of lethal weapons, if any. Further, I want to review with them whether they have any history of depression in the past or mood swings, and also any anger, bad tempers, road rages, anxiety, panic attacks, agoraphobic symptoms, any obsessive compulsive symptoms, namely excessive hand washing, superorganized, putting things in perfect order, checking, counting or any rituals. Further, psychotic symptoms such as feeling paranoia, hearing voices, hallucinations, delusions and disorganization of thoughts and behavior, have that been a part of their previous history, any history of eating disorders such as bulimia, anorexia, overeating, any premenstrual syndromes, any conduct disorder, oppositional defiant and sociopathic behavior, or any jail or prison sentences. Further, attention deficit disorder symptoms or attention deficit hyperactivity symptoms. Further, appetite problems, alcohol, nicotine, excessive caffeine, marijuana or other drug abuse. It is very important to record the family history, namely the ages of parents and the siblings and their professions, and which side of the family has any mental or alcohol or substance abuse problems, Also record whether grandparents, uncle, aunts, cousins, and patients' children have similar problems, especially were they drinking, have they had any suicide attempts, or any bad tempers or mood swings. Further, I do record where they were born and raised, what is their level of education, and what is their current profession. I also record their marriages, divorces, children, and their names, ages, and profession of spouse, and also record while growing up, was there a problem in childhood, were there any physical, emotional, or sexual abuse, and what are their current stressors. This is very important that we have noted those things, and also who are their supportive relationships or support from church, family, friends, and strengths of the patient. Do they have a good education? Do they have a good job? Do they have a good family support? Further, whether they do any exercise or have any hobbies, or their eating habits, as well as their current body weight, and thereby calculate the basal metabolic index. It is very important at the very outset to record what is their level of functioning, and I do on a scale of 1 to 10, namely 10 is their best functioning, 1 is their worst functioning. The assumption is that with the burden of psychiatric illnesses, their functioning is not normal, and likewise they are functioning at home, profession, school, or in social settings are recorded. Also, I want to know what is the level of their symptoms, namely on a scale of 1 to 10. If 10 are no symptoms, 1 are the worst, I do record their depression, anxiety, obsessiveness, alcohol, or any other symptom that they are presenting. Likewise, it is important to record those relationships, namely with their spouse on a scale of 1 to 10, and I do ask them what is their relationship with their spouse, even at the most intimate level. Further, the mental status examination is recorded, such as appearance, behavior, eye contact, orientation, speech, mood, affect, thought process, context, memory, intelligence, insight into their illness, and judgment. And thereafter, I formulate a diagnostic impression based upon the collected information, and I still go to the axis 1 to axis 4. Axis 1 are the psychiatric disorders, axis 2 is the personality disorder, axis 3 are the physical condition, the physical problem that they are having, axis 4 is the level of stressors, and axis 5 is the functioning. However, the functioning that I described above is probably more valuable than what is proposed in DSM-4. Furthermore, I do design a treatment plan and share with the patients what kind of medication I am selecting, and why so, and also any psychotherapy. And in that regards, I do ask them if they have any questions that they want to have any answers for. If they come with their spouse, if they want me to have them come, or their parents, I do ask them to come, and I explain to them what's going on with the patients. Further, in the very important part is what kind of medication we select. Again, let's say in the case of major depressive disorders, if that is one of the diagnoses, then depending upon the current symptoms, I select either serotonin reuptake inhibitors or the serotonin and norepinephrine, so-called SNRI, or bupropion, which is Wellbutrin, mirtazapine, or nifazodone. But again, these are matched to the symptoms. Namely, somebody is not eating, somebody is not sleeping, has lost a lot of weight, I'll go for mirtazapine. And if somebody has got problems with any kind of attention and focus, I'll probably pick up bupropion. Likewise, major depressive disorder with generalized anxiety disorder, I would select a serotonin reuptake inhibitors such as fluoxetine, citalopram, and sertraline. And again, my first choice is always fluoxetine, because it has a longer half-life. It is useful for so many other conditions such as obsessiveness, PMS, and also bulimia. Further, if patient has a panic disorder along with the depression, I select the serotonin reuptake inhibitors and also give a low dose of benzodiazepines such as alprazolam or clonazepam on as-needed basis. And if the patient has major depressive disorder with obsessive compulsive disorder or bulimia, my first selection is always fluoxamine, which is at a higher dosage. And likewise, major depressive disorder with ADD symptoms, bupropion is the first choice, and with other antidepressants, one can certainly add on the stimulants such as dextroamphetamines or methylphenidates. Likewise, if a person has major depressive disorder with cigarette smoking or nicotine dependence, bupropion is my first choice, and if there are other medications to be selected, I do discuss with them to start on Chantix or Vernaculine. And patient with sleep or weight loss, mirtazapine is my first choice. Again, major depressive disorder with alcohol use disorders, antidepressants, and I add on naltrexone so that to reduce their cravings for alcohol. Major depression with chronic pain, my first selection is either venlafaxine or duloxetine, and depression with resistance, namely they have not responded to any of the above described antidepressant medication, then I do add on bupropion or mirtazapine or lithium or T3 and stimulants or second generation antipsychotics. Furthermore, patients who have got depression with PMS symptoms, again any of the SSRI should do the job, namely fluoxetine, citalopram, sertraline, but patients who have a depression with psychotic symptoms have further, in addition to the antidepressants, a addition of antipsychotics such as risperidone, Abilify, haloperidol, or thiothixine. Any person who has a generalized anxiety disorder, again SSRI are the first choices, namely fluoxetine, citalopram, sertraline, and panic disorder symptoms have again SSRI plus low dose of benzodiazepine on as needed basis, such as alprazolam or clonazepam. And patients with obsessive compulsive disorder, fluoxetine at a higher dose, 40 to 80 milligrams, is very well tolerated, and other alternatives are fluoxamine and anafranil. In the case of bipolar disorder, my first choice is lamotrigine, followed by carbamazepine or oxcarbazepine and lithium carbonate or valproate for manic symptoms, and antidepressants for depressive symptoms. For attention deficit disorders, again I select the dextroamphetamine derivatives or methylphenidates, and alcohol use disorders, naltrexone or disulfiram, which is antabuse. For schizophrenia and psychotic symptoms, first or second generation antipsychotics are probably the best choices. Here is a selection of medications for personality disorders. Again, this whole area is not at all well documented as well as well researched, but if we make the assumption that personality disorders are due to abnormal brain chemistry, then in addition to therapy, they should be successfully treated with medications. And my choices are here enumerated, namely paranoid personality disorders, antipsychotics; schizoid personality disorders, again antipsychotics; schizotypal personality disorders, antipsychotic medications; histrionic personality disorders, probably mood stabilizers; avoidant personality disorders, serotonin reuptake inhibitors or bupropion; dependent personality disorders, again serotonin reuptake inhibitors, bupropion; obsessive compulsive personality disorders, the SRI, serotonin reuptake inhibitors; and borderline personalities, which present a huge different complexity of symptoms. I think we may have to select 3 or 4 medications to bring their symptoms under control, such as mood stabilizers and serotonin reuptake inhibitors. Now, once I have explained to the patient my rationale of starting them the medications, I always start low dosages to be built up very gradually, and if they are experiencing side effects at the higher dosages, I ask them to go back on the smaller dosages. And in the follow-up care, when they come to my office, I always record what is their body weight and discuss changes, if any, list of the current medications and how much are they taking based upon what I prescribe to them, and have they been adding anything else, and also are they seeing any therapists or going to support groups such as AA or NA meetings, and what are the positive changes or improvement in symptoms from their previous visit. It is very important to record those ones, because very often patients forget their original symptoms and they don't know that they have definitely made improvements, and they want to go being totally free from all the symptoms, which of course is not possible, because we are still trying to titrate the medications to them. But it is very important to record the positive symptoms so as to bring confidence in them, as well as to the treating physicians, that whatever they are doing is helping them. Likewise, I also record their negative changes or side effects of medications, then improvement in work, of the functioning at work, home, school and social settings. Further changes in relationship with spouse, children or others that have anybody else. Notice any change in their behavior. Although it is too early at the initial stages, but sometimes these changes are very dramatic. And also whether they have reduced their abuse of alcohol, nicotine or caffeine or drugs, exercise or physical activities are emphasized again, suicidal thoughts if any are recorded, and then a brief mental status examination is also recorded, and also encourage patients to focus on the positive changes, to be more hopeful and optimistic. And the increase and decrease, deletion or changes to different medications is also explained to them and the rationale for it. Further, I always try to be gentle with the changes, because everybody is different and we just cannot increase the medications by big double or tripling the dose. That's not a good idea. Further, I emphasize good food, exercise, yoga, meditation, relaxation and good sleep, and give a follow-up appointment. Now, very often when it is a primary care physician or a OBGYN or a pediatrician or any other physicians who sees any abnormalities that they cannot handle or they don't feel equipped, then they should be referred to a psychiatrist. And these are some of the recommendations, namely patient with history of psychiatric hospitalizations who are not getting well, they should be referred to a psychiatrist. Likewise, patient with moderate symptoms of schizophrenia, mania, depression or anxiety disorders who are not getting well, they should equally be, if the primary care cannot bring all the symptoms under control, they should finally decide to send it to a psychiatrist. Further, patients on leave and who are on disability from work should always be sent to a psychiatrist for a urgent evaluation. Likewise, treatment-resistant patients and also patients with severe alcohol and drug problems, patients with postpartum psychosis, because that's a big danger to the baby. Sometimes we have seen that they don't recognize their own babies which are born, and they must be taken very seriously. And I have a case where the patient was running away or they wanted to kill their child, and I think that needs immediate hospitalization and attention to a psychiatrist. Likewise, patients with chronic physical problems such as pain, headaches, gastrointestinal problems, cancer, AIDS, cardiac problems, dementia, who are not getting well should be referred to a psychiatrist. I must add, in the referral, if patients are feeling suicidal, then immediate referral to a hospital is extremely important. Now, in this video, I have described a model for psychiatric evaluation as well as the choices of my medications and a treatment plan and a follow-up care. I hope that these models are helpful to you, and I have also described the criteria for referral to a hospital or a psychiatrist.